Hi, my name is Dr. Lisa Belvy, and I'm a licensed clinical psychologist located in the San Francisco Bay Area in the United States. I'm very excited to be speaking with you all today about pain management strategies for EDS and HSD from a psychological perspective. So let's get started. I have nothing to disclose. So, first things first, EDS and HSD-related chronic pain is not in your head. And this is despite what physicians may have told you or implied, or something you've wondered yourself. There are many physiological explanations for the pain, and this is just a short list here. So if you haven't heard it or haven't heard it enough, the pain is not in your head. But that being said, all pain is processed in the brain. And this is whether it's pain related to hypermobility, cancer, an injury, all pain is processed in the brain. So you might imagine that other events in the brain and nervous system will influence the pain experience. So I'm going to give you an illustration of this so maybe you can sort of get a felt sense of it. So I'd like you to imagine that you are having an amazing day. You are sitting on the couch with one of your favorite people in the world, laughing, joking, maybe talking about old times, and you get up from the couch and you stub your toe hard. Ouch, ouch. I did not expect that. You can imagine yourself sort of laughing, smiling, shaking it off, maybe giving your friend or family member a glance and then walking off. Now I'd like you to imagine that you stub your toe on one of the worst days of your life. Maybe you've just gotten bad news. Maybe your health symptoms are really flared up. You're sitting or lying on the couch and you get up and you stub your toe hard. Ow, ouch, that hurts. Ugh. Nothing is going right. Nothing is going well. So you can sort of imagine you might have a greater pain intensity. The pain may linger for longer. So what is the difference here? Well, our sense of safety versus threat in our nervous system, our mood, and our interpretation of the pain influences the overall pain experience. So this is partially captured in the pain psychology literature with the idea of pain catastrophizing. And I put catastrophizing in quotes because it's not the most patient-centric language. So no one likes to think of themselves as a catastrophizer. It sounds very dramatic. So I like to think of it as unhelpful things our mind tells us about our pain. So see if any of these seem familiar to you. This pain will never get better. I'm not going to be able to go to the party, meeting, or outing. Pain has ruined my life. This is unbearable. There's nothing I can do to stop this pain. So what do we know about this type of thinking, this pattern of thinking? What does the research say? Well, it is linked to greater pain severity, disability, and emotional distress. And there's also a sizable amount of research that looks at how physiological mechanisms might relate this pain catastrophizing pattern of thinking with these negative pain outcomes. So one thing important to highlight here is that much of this research is an association, a linkage. So pain catastrophizing is associated with these variables. But very likely the relationship goes both ways. It's bidirectional. So you can imagine if you have greater pain severity and disability, your brain might be more likely to engage in this negative pattern of thinking. And then as a result, you might experience increased central sensitization or your body being more sensitive to pain signals and maybe increased muscle tone in the areas where you typically have pain. It ends up creating this pain escalation. So, yikes, that doesn't sound very good. So give me something, hopeful here. Well, the good news is that treatments that are associated with reduced pain catastrophizing are associated with reduced pain intensity, improved functioning, and less disability. So now we're talking. So how can we leverage this knowledge and try to improve our own pain experience, our own pain outcomes? Well, there are helpful things we can tell ourselves. I can handle this. I've done it for years. I might still be able to go to the party. Let's wait and see. If I take a rest, my body might reset. I can do this. I'm a survivor. I have some tools I can use. Let's try them. So if you've been able to use this type of thinking for yourself and it's been useful, excellent. Keep up the good work. And if you're looking at this list and thinking, I've tried that, Dr. Belvy, it doesn't work for me, or that those statements don't feel authentic to me. I don't think I can genuinely tell myself that. Well, if you're thinking that, you're onto something, because the key here is that we have to believe them. We have to believe these things for them to have their positive effects. So we can't will ourselves to believe them. We have to show ourselves. We have to show our bodies. So how can we do that? Well, first I want to start with activity pacing. So this is one of the most important tools a pain psychologist can have in their toolkit. So helping folks pace the activities that lead to pain. And this might be walking, standing, sitting, using a mouse and keyboard, cooking, biking, you name it. Any activity that for you can lead to pain. So what we want to do is take a break from the activity before we need to. And I can't stress this enough. The before we need to is very important, because we can all imagine, you're going on a walk and your knees start to hurt and you take a break. Maybe you take a break if you're not being sort of stubborn that day. So you take a break in response to the pain. But here it's very important that we take the break before the pain alarm bells go off. So how do we do that? First, we have to know our baseline. How long can I walk, in this example, without my pain increasing? And once we know what that is, we can shave a little bit of time off of that and take a break before we get there. Now, the break could be rest, or it could be an alternate activity, maybe that uses different muscle groups and joints and just doesn't flare up our pain in the same way. And then importantly, we resume the activity. We're not done with it. We're going to come back to it, but it's after we take an appropriate break. Then the idea is that we gradually increase the time over time. So we're not just going to stay where we are. We're going to progress it. But especially when it comes to EDS and HSD, we're going to do this very, very slowly and gradually as we are able. So what does this look like in a more graphic form? So you can see that first row up there, an example of activity without pacing. So in this walking example, let's say that you can walk 12 or 13 minutes without your pain alarm bells going off. So, but you decide one day that you want to walk for 30, because 30 that's a full workout, right? I'm going to walk for 30 minutes. Well, you can do that, but as you may have experienced, you might be laid up on the couch for the rest of the day. You might need to rest much of the rest of the day because you've gone way beyond what your body is allowing right now. So imagine that you pace the activity instead. So for that second row there, we have the activity being walking. So you do it for 10 minutes. So what I've done here is I've shaved off a few minutes from those 12 to 13 that we know we can do without the pain increasing. So you take a break after 10 minutes. Maybe you sit on a park bench, you lie down on the grass, whatever is a good reset for you. Then you resume the activity, you rest, you resume the activity, you rest. And if we do some simple math here, you can see that you've walked for 30 minutes, but you've done it in an hour, which is more than 30. However, you're not laid up on the couch the rest of the day. So it's actually more efficient in terms of your time. And there's also a lot of psychological benefits as well. So what we're doing here is we're teaching the brain that the activity is not painful, or not always painful. It allows us to develop more self-efficacy, or a sense of control and confidence in what we're doing, and less fear around the activity. It also, over time, is meant to improve our functioning and, as a result, enhancing our well-being. So, what are some special considerations in EDS and HSD specifically? Well, as I alluded to a moment ago, there are many activities that we might need or want to pace, whether it's walking, sitting, standing, all of the above. So I recommend picking one, starting somewhere. And once you get that under your belt, where you're pacing, you're sitting, or you're standing, then you can start to slowly incorporate others that you're working on. With our hypermobile bodies, there also may be some activities that pacing may not be helpful for or helpful for now. And I use the example of running. Most of my clients are not able to run. I'm not able to run. And so that may not be something we can effectively pace and get to. It also can be hard for those of us with EDS or HSD to figure out rest position or activities. So I'll give you an example. I am limited in how long I can sit for. So many years ago, I was trying to pace myself with a sit stand desk. So I thought, I'd sit for a while, I'd move my desk up and stand for a while to be able to continue my computer work. But what I learned was that the standing was actually really hard on my knees, and I couldn't stand long enough to allow my sitting break enough time. So it just wasn't a good activity for me to try to pace with. So I stopped doing it. It wasn't a good fit. Instead, I've done two things. One is learned that lying down is my best break or reset, so lying on the couch. But I've also been able to increase the amount I can sit by changing my actual positioning a little bit, that actually provides a reset for me. So for example, I sit for 20 minutes in a regular chair position, and then 20 minutes in, introduce a lumbar support, and now I can sit another 20, and then I get up and take my lay down break. So figuring out how, what's going to be a good break or reset for you. It's also really important to consider other conditions we may have, such as POTS. And particularly for you providers in the room, I want you to pay attention to this. So if, for example, in the sitting pacing, maybe your knees are stronger than mine. Maybe it wouldn't flare up your knees to stand for a while. However, it might be hard for you in terms of POTS. If you're trying to stand for 5-10 minutes, you might become lightheaded. It might not be a good break for you. So really important for providers working with folks on activity pacing to consider these other health conditions. Also, as you may have experienced, our symptoms are often variable. So the time before the pain alarm bells go off and our need for rest changes over time. So just being responsive to that. Maybe there are times you can only walk for a few minutes without pain increasing, or maybe there are times where you can walk for 20. So just paying attention to that and modifying your baseline as needed. Okay, so that was activity pacing. Now I'm going to switch gears and talk about another category of things that fall under regulating or calming the nervous system. So we can modify our pain experience by creating a sense of safety in our body and nervous system, by decreasing our sympathetic or fight and flight activity, and reducing stress, fight or flight, by the way. So trying to reduce that. So there's a whole category of relaxation training exercises. The first there, I'm sure you've likely heard of, diaphragmatic breathing or deep breathing, which involves taking a deep, slow breath. And I can demonstrate here. So breathing in slowly. And very slowly breathing out. I recommend doing that for a few minutes to get the full effect of the deep breathing. There's also autogenic phrases. So these are short phrases that we say to ourselves to give our body some instruction. It's a form of self-hypnosis. So I'll give you a short example here. So repeating to ourselves, my body is relaxed and calm. My body is relaxed and calm. My body is relaxed and calm. Ooh, and even as I'm saying that, I'm feeling a little more relaxed and my spine was sort of straightening itself up a bit. So repeating these phrases to ourselves. There's also guided visualization. So that is imagining a scene in as much sensory detail as possible. So if you're imagining a beach scene, for example, you're imagining the warmth of the sun on your skin, the smell of the salty air, the sound of the waves ebbing and flowing, maybe what you're seeing, a seagull flying off in the distance. You're immersing yourself in the scene with all of your senses. And then progressive muscle relaxation involves progressively tensing and relaxing our muscles, going through the whole body, toes to head or head to toe. And for all of these exercises or types of exercises on here, you can type these words into, search online for video or audio recordings that will guide you through. There's a lot of free or low-cost resources online where you can engage with all of these relaxation exercises. And if you're finding that they don't quite work for you, or you seem a little too vulnerable as you're doing it, especially for those of us who have a more significant trauma history, it can be helpful to introduce movement so we feel less threatened as we're doing it, especially if we're trying to do it lying down with our eyes closed. A small change is you could try doing it with your eyes open and perhaps rocking in a rocking chair or gently pacing around your bedroom or your backyard while you're doing the exercise. And that may, make it more palatable for you and your body and nervous system. Or there are movement-based approaches like Tai Chi or Qigong that might be helpful for you that you enjoy and respond to. So the important thing is finding what works for you specifically and going with that and using the exercises that work in your particular body. There's also mindfulness for chronic pain, and I could do an entire presentation on this, but I'm going to do it in one slide here. So basically, it's training a different response when pain arises. We are observing sensations, not judging them, and noticing that all sensations are temporary. This idea of impermanence can be really powerful and potent. Because if you think about it, thinking about managing our chronic pain for our whole lifetime just feels overwhelming. It just feels, how can I possibly do that? How can I cope with this? But if we change things and approach it as I'm in the present moment and I just need to cope with this pain or experience these sensations for this minute or this moment, it all of a sudden becomes more approachable. Like, okay, maybe I can do this. I highly recommend the work of John Kabat-Zinn here in the United States or Vitamala Birch in the UK. They have both written books, but also have audio recordings that you can purchase, that are very useful. I use both of their work and highly recommend it. So, in conclusion, with more tools in our toolkit, pain feels less scary and overwhelming, and we feel more in control. And as we're able to use these tools successfully and they find that they are helpful for us, we can actually tell ourselves things that are helpful because we've been able to demonstrate them to ourselves. We have a felt sense in our body that we can get the pain intensity to decrease a little bit, or that if we pace ourselves, we are able to engage with that activity. And by telling ourselves this, it further decreases the pain-promoting nervous system activity and those physiological effects I was mentioning earlier. So basically, we are now creating a pain de-escalating cycle where we're using the tools effectively. They're helping us. We're able to tell ourselves, hey, I can do this. I'm a survivor. I have these tools. Further decreases that nervous system activity that might be promoting pain, and on it goes. It's not easy, but you can do this. We can do this. So thank you so much for your time and attention today.